Hello, Anish. How are you?
Good, Michelle. How are you doing?
Pretty good. Anything exciting going on this week?
No, not much. I'm sleep
No.
deprived. I've
Goodness.
been awake since the wee hours of this morning with trying to make binary decisions clinically. Do you
Right.
place a transvenous spacer or do not place a transvenous spacer?
Yes. Transvenous spacers do not work. EBM has shown that transvenous spacers do not work.
Yes, yes.
Good.
Yeah. Will this resolve on its own? I hope it resolves on its own because it's 3 a.m.
Right. So we
Somebody,
have, yeah, we have a paper to talk about that's
yes.
not exactly new and not the typical kind of EBM related paper. This is a paper by Jeff Flier, former dean of Harvard Medical School, and Jared Rhoads. And it's a white paper that they published on the website of the Mercatus Center at George Mason University. It has to do with health policy and healthcare economics, and it has to do with the UL. The title is the U.S. Health Provider Workforce. Should I summarize it in like maybe 2 minutes?
Yo, please. Yes.
If I can. I mean, it's a
If you can. It's hard
58-page
to do.
paper, so it's hard to do.
Good
But
luck.
the gist of it is that they say, in a nutshell, okay, healthcare is a mess, but everybody's paying attention to the demand side of things. You know, access and cost and insurance, making sure everybody has insurance and all that stuff. And people are not paying attention to the supply side of the equation, in particular the supply of physicians and basic supply and demand. The law of supply. If you increase the supply of physicians, you can improve access and reduce cost and so forth. So the paper is a huge, a very detailed overview of the current regulatory system that dictates how many doctors are allowed to practice, what they're allowed to practice, and who else is allowed to practice that could also increase the supply of medical professionals. So they go in detail uh, uh, about all these all the regulatory factors, and they give a little bit of a historical background, and then at the end they make their recommendations, and their recommendations are fairly modest as far as I'm concerned. What was your so I'm not going to give the recommendations. I'm going to let you chime in at this point and tell me what
Yeah.
you think.
No, it's a very dense paper that goes over a lot of things and makes a fair number of recommendations. And I think you're absolutely right. So what struck me was that they think that the solution here is increasing the supply of folks that can be practitioners, and that's by using non-physician providers. So we finally get to the root of why you can't call people doctors anymore and why everyone must be a provider.
Right.
And they specifically want new schools, more doctors. They want more foreign trained physicians. They want, of course, to use non-physician providers as we're talking about. And there are many different issues I have, but I'll just say that they put everything in a wrapper of strong facts, and they say, well, obviously, X assumption is true, and they cite some paper, and then they go on based on X assumption to say Y. So the one thing that jumped out at me is this constant assertion that's made that in every study that's done, NPs are just as good as physicians, and and they'll cite the published literature. Now, a lot of that published literature comes from conflicted sources, meaning sources that have will have an agenda in
In
that
promoting
paper being one way or the other. So I found some of the pillars that this stuff rests on to be pretty soft. There's a BMJ meta-analysis that they quote from 2000 where they're again looking at NPs versus MDs, and I just wanted to go through just some of the specifics of that. These were they looked at same day patients that were coming. These are patients that had same day acute issues that need to be seen. The outcome was patient satisfaction, resolution of symptoms. They took 1,700. They screened 1,700 folks. 200 or so refused. 1,400 that were remaining were then randomized to either a primary care physician or an NP. And these were not NP only practices. These were NPs that were part of larger physician practices. And you can already see the issues with that, right? I mean, what happens all the time? I mean, I've had nurse practitioners that work with me, and when a nurse practitioner faces something in their room that is something complicated, what do? They come to me and say, hey, what do you think about the CKG? Or, what do you think I should do about this particular case? Because they're relying on the greater experience that physicians frequently have. So there's no separation, and there's no separation or no blinding or whatnot here. On top of that, the paper is painted in a very positive light for practitioners or providers or non-physician providers in saying that the outcomes are the same, satisfaction is the same, etc. But there's a nice little statistic that's lost in all this. If you saw a general practitioner, and then you ask in this study, who do you want to see the next time? Only 8% said, oh, next time we want to see a nurse practitioner. If you saw a nurse practitioner, right, for whatever acute same-day issue you had, 48% said they wanted to see an MD the next time, right? And all this granularity is lost because patient outcomes was the same for same-day colds, right? Like same-day visits, almost 99.9% of the time, everyone will get better. They can see an AI bot, they can see my pet Chihuahua, or they can see an NP, or they can see an MD, and their rash or whatever it is they're seeing is going to get better. So it's more of this agenda-driven white paper that's again dressed up as objective truth, and this is what the evidence says. And hey, we're not taking a position one side or the other. This is just what the evidence says. That's total baloney. That's not what the evidence says. This is what you say the evidence says.
Right. It may be. It's possible. I didn't read it as so obviously biased in favor of nurse practitioners, but maybe you're right. I mean, what struck me, I think the angle that they're coming from is that they're seeing that there's a lot of regulations. So in fact, so this is published for people who don't know, the Mercator Center is for the most part, a pro-free market think tank at George Mason University. So I was excited. I thought, wow, Jeff Flier, Dean of Harvard, pro-free market. This is great. Let's, I'm going to look for, real calls for deregulations. And so they spend a lot of the paper talking about how many layers of bureaucracies there are that impinge on the supply of providers in general. And I'm sympathetic to that. I mean, I think there are too many layers, and I think there should be, we should remove those barriers. And I really, I'd be perfectly okay if NPs wanted to hang their own shingles and do that. But as you said, provided that patients are in a system that gives them freedom to choose, which right now they pretty much don't, right? They have no freedom to choose for the most part. They get told to go, they get to go where they're told to go. And so yes, I mean, I think it is in that sense, it's a little bit disingenuous. I was also disappointed by the modesty of the proposals at the end. So they talk about how all these bureaucracies are sclerotic and they're set in the old ways and nothing's changing, and the curriculum is too long and it takes forever for MDs to graduate and all that stuff. But at the end, in terms of their recommendations, they're like, wow, it would be nice if the LCME that regulates the medical schools if they would loosen up a little bit the curriculum, if they would, embrace new approaches and things like that. What, just, I mean, how, this is not going to change the way things are done. To just ask the LCME to please, why don't you consider, a shorter curriculum for medical schools and that sort of thing. I was hoping that they would say, we need more competition. We shouldn't have monopolies in these regulatory agencies. I mean, as the first thing, nobody's going to go my way and ask for an immediate deregulation and abolishing of all these bureaucracies. That would be nice, but I didn't expect that. But I was hoping at least that they would say, why don't we have competing regulatory agencies that accredit training programs and accredit medical schools, because right now there's only one accrediting agency. So all medical schools have to please the LCME and have to go by what they say. And the LCME is a bunch of bureaucrats, and all they care about is, to continue to do what's been done for the last 100 years, and not do something that could potentially, reflect poorly on them. So the inertia is enormous. And really,
Right.
the only way to get out of it is to try to add, to have competing regulatory agencies come in and loosen up. But you're right. I mean, having more nurse practitioners, and bless their hearts, some of them are working really hard and so forth. But you're absolutely right. They don't have the same experience, and it wouldn't be the same care. And if this was, if we are aiming for some sanity in the healthcare system, the patients would be free to choose. They would probably seek out the doctors more, as you said, but then the doctors would probably fetch a higher fee, presumably, which brings an important question. And I'm sorry, I'm talking too much here, perhaps, but at the beginning of the paper, they admit that we're not sure if the supply of doctors is too low or too high or optimum. We actually have no idea if there are too many doctors or not. What are your thoughts on that?
No. Yes, it is my nature to focus on these small things. It is your nature to burn down everything. so no. I guess you are not just proposing. You would extend beyond what they're saying. They're saying
yes,
drop barriers to foreign medical graduates entering. You're saying that
bring them in.
Yeah, you're saying that who says that there should be one group of folks that say who can and cannot practice medicine. It should be anyone, and let the patients be the ones that choose.
Correct.
All that. So
let's chips fall where they may.
Yeah. It makes I'm a protectionist at heart when it comes to physicians. So
you voted for Trump. I'm not surprised.
Exactly. It makes me that whole thing makes me nervous. But certainly, I would worry, Michelle, in your proposal. I know. I mean, I guess now we're not talking about what they proposed. We're talking about your proposal. But how there's a fair amount of information asymmetry, right? And
yes.
And obviously, there are charismatic snake oil salesmen.
Yes.
How do we prevent charismatic snake oil salesmen from treating your pancreatic cancer?
Right now, we're not preventing them. Is the system preventing right now charismatic snake oil salesmen? Is Dr. Oz not licensed?
No.
Is our homeopath or whoever not allowed to practice? So
well, there would seem to be some repression, meaning the medical establishment, with the weight of our certifications and our boards and our whatnot, says, well, we are real medicine and they are fake medicine. So
right. And that's a double-edged sword as far as I'm concerned for us. So on the one hand, it funnels a lot of medical dollars towards the licensed guys.
Right.
So we get the Medicare and all the insurance money, because we're recognized as holding the license,
right,
and so forth. But on the other hand, you get all the scrutiny and the quality measures, and because having a license is clearly not enough, because you need MOC, you need quality measures, you need 100 clicks a minute on the EHR, you need all these things. So the bottom line is that the third party payer will never trust you, no matter how many credentials you are, no matter how good you are, and he's the third party payer is making your life miserable, whether it's the government or the insurance company.
But Michel, yeah. No, go ahead. Yeah.
So, but you were talking about the asymmetry of information, and patients know, they certainly know better than the bureaucrat, who's qualified and who's not. I mean, right now you have a license. I tell you, you can put the stent in the wrong artery, or you can cut the wrong leg, and you still get paid because the code is the same, right? If you malpractice, unless you get caught by the patient, you can fill out the same code, you can pay the same thing, and right now we're providing terrible care. Patients are waiting, the weeks and weeks to see a doctor. It's congested. We spend 7 minutes per patient. It's horrible. And so I think, I think it's not working. It's not protecting the patients, and it's not reducing the asymmetry of information problem, which exists. But it exists when you buy a car. I know nothing about cars. I know zero about cars. But it doesn't make me completely helpless. I can go to consumer reports or Edmunds or whatnot, and there are, the market will provide the information that I'm lacking, to balance, and that can happen in healthcare as well, and actually does happen by virtue of what it should be. It should be your medical school, your degree, that should really reassure the patient that, okay, you went to a good medical school, and the medical school should be, they're not right now, but they should be held accountable if their graduates are not practicing well. But right now they don't care, because since we have a system of licensing, all they care about is that their graduates pass the licensing board, and that's all they care about. And after that, the paradigm is that you get a license. I mean, that's the paradigm from 100 years ago. You get your license, you're good to go, and so there's no incentive for the medical schools to be a check, an ongoing, and it could be an ongoing check. I mean, I'm not against voluntary oversight. I mean, if I want to show patients that I'm doing, that I'm competent, I'm gonna ask for independent agencies, or to certify me in a way, but it has to be voluntary. Right now it's not voluntary, and therefore you get organizations like the ABMS that are run amok. They do whatever they can. So you have monopoly over the certification process.
Right. So they have competitive regulatory agencies and stuff. I just wonder how easy it is for patients to certainly parse, what's a good medical school, what's a good regulatory agency, or not. But in general,
by word of mouth, they would. Word of mouth is very, very effective, and much more effective than people realize. Because right now, I mean, we've been in the mode of saying the patients don't know anything. I mean, that's been the mode for the last 100 years. I mean, saying the patients can't tell the difference and so forth. Well,
I guess I'd feel much. Yeah, I guess so. I mean, I feel much better about the whole situation if we could focus on improving the talent pool of physicians. Meaning, the question is, would your system result in an ever better talent pool of people practicing medicine?
Yes, because there would be, because if the patients decide, they will, they will reward the good talents, and so the talent pool should of course improve. But it would be the job of the medical schools. I mean, they will have the freedom now to improve their curriculum. The curriculum has not changed in 100 years. Yeah. For the last 100 years, it's been the same paradigm of 2 years of basic science and 2 years of clinical. Hasn't changed in 100 years. If you read the Flexner report, that's exactly what the Johns Hopkins was doing at the time, and it's still what we're doing 100 years later. That's completely ridiculous. If we had deregulation, medical schools would have the incentive to be innovative, to continue to produce recognizably competent doctors, and then the patients or their proxies, whoever the patients choose as their proxies, independent proxies, would pay attention to your education. Right now, patients don't pay attention to what school you've gone to, barely. I mean, some of them do, but for the most part, we're interchangeable because we're all licensed, right? By the virtue of having a license, we're all interchangeable.
Right. The one of the things they've called for is also lowering the barriers to having foreign medical graduates come in and practice. So not only would they have to curate, the American medical schools, they'd be curating the Pakistani medical schools as well. So
right, some of which are actually very good. But again, as for me, it's all good so long as, I mean, the first thing to do is to increase the freedom at the patient level. And right now, there's no freedom at the patient level.
Yeah.
Right.
Yeah.
And
you're right.
So in that case, I'm with you. I mean, I understand your concern. I mean, the patients have no freedom. We're up to the neck in regulation and whatnot, and there's nothing here that seems to change that, except that on top of that, we're going to have more competition, more competition on top of that.
So I think you and I are in agreement that if you take this system and you do what they're saying, I think I think it'll make the workforce that cares for the nation's health worse.
I agree. Yes, I agree. I agree.
Unless you do some massive burning down, like you're talking about, and burning down of institutions, which actually results in patients being able to choose good folks. And you are right. I mean, already patients do that. So we make a lot of information asymmetry. But I mean, how do little guys like me survive? It's like, I X, Y, and Z heard that we had a good experience in the hospital, or you took really good care of my mom, and that's why we're here. And there's certainly currency in that. Just to point out, though, again, another thing that's quoted in terms of another pillar in terms of like, well, this is fact. So the fact is, we've already gone through one, right? Nurse practitioners are just as good as physicians. Number two, foreign medical grads clearly are just as good as U.S. physicians. They quote some paper that is published by a guy named gentleman Norsini. Mr. Norsini is president and CEO of the Advancement of International Medical Education and Research, FAIMER Institute, FAIMER.
By coincidence.
Yeah, total coincidence, right? Again, the folks that are so EBM, like they will tear to shreds anything that is not an RCT. But again, they will, if it suits them and it goes along with their worldview, they will quote this is a retrospective study of inpatient record from Pennsylvania, 2003 to 2006, looking at CHF and MI diagnosis. If the patient had heart failure, so they looked at U.S. medical grads, and they looked at foreign medical grads, and they looked at heart failure and MI diagnoses, and they looked to see, depending if the attending record was a USMD or a foreign medical grad, what the outcomes were. CHF hospitalizations were excluded if the patient was transferred to another hospital. You and I know, anyone who works in the system knows that the vast majority of foreign medical grads right now do not sit in tertiary care institutions. A lot of them sit at community hospitals. A lot of community hospitals transfer out their sickest patients, right? So they're excluding all the patients that get transferred out from community hospitals when they're doing their analysis. They also, the difference, again, that is given as oracle-like evidence for why U.S. MDs and FMGs are equivalent, or FMGs may actually be better, is a statistically significant 5% versus 5.5% difference in outcomes, right? I mean, this is just emblematic of the fundamental problem with health policy research. I mean, it's really absurd. And this is all agenda-based activism. Whether the activism comes from the free marketeers or the pretend free marketeers, as you're saying,
right, pretend free marketeers, right,
or whether it comes from the folks on the
right. Just for so as not to paint them in a worse light than we have so far, I tweeted to the authors that I thought they were not going far enough, and one of them answered that he would he'd be very glad to be more radical pro free markets if he if the academic environment in medical schools and healthcare wasn't so anti-free market to begin with. So he was implying that that's only as far as they could go.
I see.
And
without being labeled heretics
right, without being
fire.
promoted and ran on the coals. But I think so. So I'm in agreement with you that if we assume that the system is not fundamentally changing, which is the assumption in this paper, then yes, since the care is going to continue to be crappy, we may as well defend our little turf. and
we'll have to talk about, we'll have to talk about, I'm a pragmatist, right? So I'm an unprincipled pragmatist.
I need to change you.
Yeah.
Right.
On these conversations at some point, hopefully I'll learn enough to develop some principles. But, there are clear examples of protecting communities protecting local communities. So whether it be the impact of globalization and impact of trade for cotton farmers in the south of India, meaning if you suddenly start allowing cotton flooding into these markets, and you have farmers in India that are already living at subsistence level rates,
right,
and suddenly you have a flood of cotton coming on the market, that means this poor man cannot hold on to his land, and suddenly the rates of suicide of cotton farmers is rising in India. Right. These are some really terrible.
Correct, but you cannot.
When you're not a pragmatist and you stick to principles.
The problem is that you cannot just in isolation look at that and say, the farmers are being hurt. Now of course they are being hurt. They're being hurt, but the entire social structure is, it's so far from the free market in general. And if you flood, and certainly, frequently the flooding of the market may not be done by free market means. They may be done sort of top down and whatnot. But on the other hand, if you have to look, if you only look at the farmers, how they're being hurt, or if in our case, stick to our case, only look at the doctors, you have to look at the patients, or the consumers, right? So in India, the consumers of cotton, if you were protecting the farmers and the price of cotton was very high, you're hurting a lot of people, who have to buy the cotton more expensively than they would if it was produced elsewhere. I don't know the details. You always have to look. There's always an opportunity cost that is left out. That's why economics is so. Economic policy always focuses on what one can see and ignores,
right,
what one doesn't see.
Right. Is it unnatural for a group that is that is under duress or under attack to
try to protect itself,
make moves to protect it? Is that not what?
No, it's completely natural. Right? It's perfectly natural. But is it, if you're going to look at the the good of the community as a whole, the good of the whole, the more freedom, the better. I think I'm firm about that. And
you're making the argument for what's good for the community being better than what's good for individuals.
No, because right. No, because it's good for the community by way of being good for many more individuals than if you're really protectionist, and if you ask, because the protectionism is always having the government intervene in some fashion or another, and they intervene. They have their pet industries that they protect, or within an industry they have their pet people that they protect, and it's like that in healthcare, and that's what it's been.
Right.
Very good. Did we beat this?
I hope so. I tried to beat it. beat it to death.
All right, Anish. Nice chatting.
Same here.
See you next time.
Take care. Yep. Bye-bye.